So once again, I'm back. So right now, I'm going to discuss the prompts from the musculoskeletal system. Actually, during discussion of the prompts, these prompts are divided into three sections. They are triple star, double star, and one star. So what does this triple star means? These triple star mean that these are the most important prompts coming in the PACES exam. They have the most number of frequencies. Then the less number of frequency are the double star, and the least important cases are the one star, meaning that they have come only one time or at best two times. And these prompts have been made from the last 4 years. So let's start from the first prompt, that is hand pain. So how to approach to hand pain? First, let me tell you that in the PACES exam, whenever any hand pain prompt is given, only you will never get any diagnosis apart from these five. They will be either joint pain or Raynaud's phenomenon or carpal tunnel syndrome or Takasu arteritis or AB fistula. This is my guarantee. Please believe it that whenever any hand pain comes in the PACES exam, this will be either joint pain or Raynaud's or carpal tunnel syndrome or Takasu arteritis or due to AB fistula. So you'll be given a prompt like that. This 40 years old male or female has come with hand pain. Please talk to her, examine her, and meet her consent. So how to approach to the hand pain? The first question will be, what do you mean by hand pain exactly? Is it joint pain? Or is it color change on exposure to the cold, that is Raynaud's phenomenon? Or is it tingling and numbness relieved by shaking and cold water, that is carpal tunnel syndrome? Or is it pain at hand while doing some activity, that is Takasu arteritis? So this will be the first question. Then we have to directly go to that we have to tell the patient, can you please show me your hand? And do you have any past medical condition that I should be aware of? Do you undergo dialysis? To identify AB fistula. And this is a very much popular case in the Delhi center. Please keep it in mind. So this will be the first question for any type of hand pain. That what do you mean by hand pain exactly? Is it joint pain? Is it color change? Is it tingling numbness? Is it pain in hand while doing some activity? Or do you have any past medical condition that I should be aware of? Do you undergo any dialysis? So you will get your diagnosis. After that, you can proceed accordingly. So after getting the diagnosis, the next thing will be analyzing the symptom using the mnemonic ODPARA. You all know what does ODPARA means. Then we have to analyze the symptom using LICOR. That is, we have to localize the pain, we have to identify the intensity, we have to identify the quality and radiation. So this is all for hand pain in general. Now let me tell you, if the hand pain is due to joint pain, if the patient tells you that, yes, my hand pain is due to joint pain, the next question will be, do you have any morning jamming? If the patient tells you that, yes, I am having morning jamming, the next question will be, for how long? Is it more than 30 minutes or less than 30 minutes? Then we have to ask, any other joint pain is there or not? So according to morning stiffness, we have to differentiate the pain. If there is morning stiffness present, the pain will be either psoriatic arthritis or rheumatoid arthritis or systemic lupus erythematosus. All this has come in the PACES exam. Psoriatic arthritis has come many times in the PACES exam, also rheumatoid arthritis, and SLA has come during this diet at the Dhaka Center. The prompt was multiple joint pain. And if there is no joint pain, for the PACES exam, there will be only two differential diagnoses. It will be gout and osteoarthritis. So, How to rule out the differential diagnosis? What will be the screening question? For psoriatic arthritis, we have to ask, do you have any skin rash? For rheumatoid arthritis, we just have to ask that we have to look at the pattern of the joint pain. Automatically, rheumatoid arthritis and psoriatic arthritis will become differential diagnosis with each other. But in the psoriatic arthritis, there will be rash. But in rheumatoid arthritis, there will be symmetrical pain, but no rash. To rule out SLE, we have to ask, do you have any mouth sore and facial rash after going to the sun? So this will be the screening question for seropositive, for morning stiffness, for joint pain with morning stiffness, that is hand pain with morning stiffness. If there is no morning stiffness, the differential diagnosis will be either gout and osteoarthritis. Up to now, osteoarthritis has come in the PCS exam. Gout has never come up to now. So how to rule out each one? For osteoarthritis, we have to look at the age of the patient, and also we have to ask about the job. To rule out gout, I will discuss it in detail during the later part, during discussion of the knee pain. How to rule out gout from the history. There is a wonderful mnemonic there, and you will get it there. But right now, I'm skipping the screening question for gout. For gout, we can at best, okay, let me discuss in the later part. So these are all for morning joint pain. Then, if the patient tells you that it is due to Raynaud's phenomenon, that do you have any color change after exposure to the cold, then we have to make it confirm that this is a true Raynaud's phenomenon. How to make it confirm? We have to ask the patient, have you noticed the color change in the form of white, then blue, then red? Here, white means ischemia, blue means stasis, and red means reperfusion. So this is the way we have to confirm the Raynaud's. Then we have to ask all the sets of rheumatological questions. What are the sets of rheumatological questions? This is there. It is there in the main PDF sheet that will be provided to each participants. So what are the questions? You can use this flowchart for any rheumatological disease coming in the PCS exam. They are, first, question of Raynaud's, that any change in color of the fingers after exposure to the cold. Then any joint pain. If there is joint pain, is there any morning stiffness? That any skin thickening. That any difficulty in this skin thickening is for the systemic sclerosis. And this is the most common prompt coming in the PCS exam, for which joint pain is there for the Raynaud's phenomenon. That any difficulty in raising the arm or getting up from the chair, meaning proximal weakness. Any hair fall. If there is hair fall, please try to remove the hair of the patient and look at the hair, because sometimes there can be some hidden physical findings, like in the form of discoid lupus erythematosus. Unless we remove the hair, we cannot identify this DLA. Then any grittiness of the eyes and mouth for Sjogren syndrome. Any eye redness, any pain at eyes, ruling out uveitis. Any skin rash, any rash after going to the sun, that is SLE. Any mouth sore, that is SLE. Any chest pain and cough, because SLE patient can have pleuritis or pericarditis. So by asking this question, we are ruling out pleuritis and pericarditis. Then any tummy pain, ruling out peritonitis. Then for any rheumatological patient, we have to ask the nephrological question, that any change in urine. What about the amount? What about the color? What about the frequency and frothiness? So I will suggest you to use this rheumatological screening question for any rheumatological disease except seronegative spondyloarthritis in the PCS exam. So what are the most common differential diagnoses for the PCS exam for Raynaud's phenomenon? The most common are the systemic sclerosis, then the mixed connective tissue disease or overlap. Then SLE is third common. But most of the time you will find the diagnosis is systemic sclerosis. And the prompt is hand pain. After entering the station, you will find that the hand pain will be due to the change in the color of the hand after exposure to the cold. So this is for Raynaud's phenomenon. Now, if the patient tells you that the hand pain is due to the tingling and numbness, which is related to shaking and cold weather, then this is carpal tunnel syndrome. And for any carpal tunnel syndrome in the PACES exam, it will be due to weight gain. The next question will be whether it is unintentional or intentional. How much weight have you put for how long? Then we can directly go to the differential diagnosis. If the weight gain is localized, that is mostly at the peripheral part, then it is acromegally. If the weight gain is localized mostly to the central part, then this is Cushing disease. If the weight gain is generalized, then it will be hypothyroidism, polycystic ovarian syndrome, and obesity due to overeating. We have to just ask the patient, where have you put the weight? Is it all over the body or to a particular body size like the hands and feet or the face, back of the neck and the tummy? In this way, we have to differentiate localized weight gain from the generalized weight gain. And in the PACES exam, whenever any carpal tunnel syndrome comes, 100% of the cases, it will be due to any weight gain. So let me give you some important tricks, important thing. That is, okay, can anyone tell me that what is the most important differential diagnosis for bilateral carpal tunnel syndrome? It is very much important because candidates has lost mark only for not examining this. Can anyone tell me what is the most important differential diagnosis for bilateral carpal tunnel syndrome?
Acromegaly?
No, differential diagnosis.
Cervical myelopathy.
Wonderful, doctor. Cervical myelopathy. Why I'm telling this? Once at the Dhaka Center at Diet 1, this case came. The prompt was hand pain due to bilateral carpal tunnel syndrome. The candidate wonderfully identified the bilateral carpal tunnel syndrome, but he forgot to check for the jerk of the both hand. By checking the jerk, we are ruling out cervical myelopathy. That is why in the PACES exam, whenever you are getting bilateral carpal tunnel syndrome, never forget to check the jerks of both hands. If time does not allow, at least check the Hoffman. Only for not checking the mark, the candidate lost mark in the physical examination section. This is real example. It happened with the Diet 1 at the Dhaka Center. So, whenever the case is bilateral carpal tunnel syndrome, never forget to check for the jerk. Then another thing. Weight gain is a very much popular prompt in the PACES exam, and weight gain will discuss separately during the endocrinology prompt discussion. But we have to keep in mind that for any weight gain, there will be 3 complications we have to rule out. They are carpal tunnel syndrome, obstructive sleep apnea, and osteoarthritis. Please don't forget this. If you forget this, you will lose your mark in the physical examination and also in the identifying physical sign. We have to rule out this complication. One is carpal tunnel syndrome, one is obstructive sleep apnea, one is osteoarthritis. So during this Diet 2 exam, the Chennai Center, one of my candidate, he passed from the exam, he got the bilateral tingling and numbness, that was carpal tunnel syndrome. That patient also had symptoms of obstructive sleep apnea, and he had been able to identify this. So how to identify this? We just have to ask, do you have any mouth snoring at night? Whenever the patient tells you that, yes, I'm having snoring at night, then we have to ask the other questions of the obstructive sleep apnea. What are the other questions? The other questions are, do you feel fresh after getting up from the bed in the morning? This is the first question. Second question, do you feel dizzy the whole day? First question, do you feel fresh after getting up from the morning? And any headache after getting up from the morning? Because obstructive sleep apnea patient will have morning headache. Then, any problem in intimate relationship, that is erectile dysfunction. Fourth question will be mouth snoring, nighttime snoring. That was a screening question. So can anyone tell me, if the patient tells you that he is having morning headache, he doesn't feel fresh after getting up from the bed, and he feels dizzy the whole day, like the symptoms of obstructive sleep apnea, what is the important safety netting you have to tell the patient?
Stop driving.
Yes, doctor. Stop driving. Yes, that is the important thing. Wonderful, doctor. Stop driving. So keep it in mind for the carpal tunnel syndrome. The next thing is tachys. That is hand pain due to tachys. It came multiple times in the PCS exam. It used to come earlier also, like the 5 to 6 years back, and it is coming again and again. So during for tachys, the patient will typically tell you that I feel pain at the hand while doing some activity. That is hand pain while doing some activity. And whenever you are going to check the pulse, you will automatically see that there will be absence of pulse at one hand, and it will be present at the other. And for this patient, we have to check for every pulse. That is radial delay, radiofemoral delay. And also, we have to check for every bruit, like the carotid bruit, the subclavian bruit, and also the renal bruit. And where to check the subclavian bruit? It has to be checked below and above the clavicle on each side. So here we have to check for subclavian bruit, carotid bruit, and renal bruit. And pulses of lower limb can be omitted. Can anyone give me the answer why this can be omitted? Or if you don't examine the pulses of the lower limb, you can you will be permitted, like you'll not lose any mark. Can anyone tell me? Because this question was asked in real cases. This case came in the Kolkata, and the candidate did not examine the lower limb pulse. And the examiner asked it, why did you examine the lower limb pulse? Can anyone give me the answer? Why we can omit examination of the pulse of the lower limb in case of tachys. Okay, let me tell you. Actually, tachys mostly affects the arch of aorta. So it is less likely affect the lower limb. That is why if even we don't examine the lower limb pulse, we can get the mark because it is less likely to affect the lower limb. And this question was asked by the examiner at the Kolkata Center. It was 6 years back. So that is all for tachys. Another thing is AV fistula. This is a popular case for Delhi Center. So these are the causes of pain due to AV fistula. This can be due to aneurysm of the AV fistula, or due to ischemic steel syndrome, or due to some local infection, that is infected AV fistula. For all of these cases, the patient with AV fistula can experience hand pain. So this is all for the differential diagnosis of hand pain. And for any case of hand pain, never forget to check the functional capacities of the hand. This is a must-to-do examination. Whatever the cause of a hand pain, never forget to check for the functional capacity. How to check the functional capacity? We can do two movements. One is make a fist and open it for me. We have to tell the patient, can you please make a fist and open it for me? And then we can ask the patient, can you please button and unbutton your shirt for me, or you count for me? So in these two ways, we have to check the functional capacities of the hand. If we don't check the functional capacities of the hand, we lose our mark in the physical examination for sure. Okay, what are the screening question for AV fistula differential diagnosis? Dr. Rashi has raised an question. Actually, there is no screening question. We have to ask about the past medical history from the patient. In the past medical history, the patient typically reply that he is a patient of kidney disease and he is taking dialysis. What about the cause of pain? Our first question will be that, can you please show me the site of your pain? Then, if the patient is having AV fistula, you have got your diagnosis. This is pain due to AV fistula. Then, during cross-questioning, the examiner will ask you, what may be the cause of pain in this patient? At that time, you have to reply that this pain can be due to aneurysm, can be due to ischemic chill syndrome, or can be due to local infection. But we have to identify the AV fistula from the past medical history and by seeing the hand. Is it clear, Dr. Raisa?
Yes.
Okay. So another candidate has also asked a question, what are the differential diagnoses for hand pain? I'm telling again, for PACES exam, these are the 5 differential diagnoses: joint pain, Raynaud's phenomenon, carpal tunnel syndrome, Takasu arteritis, and AV fistula. After entering the station, our first question will be, what do you mean by hand pain exactly? Is it joint pain? Is it color change on exposure to the cold? Or is it tingling and numbness relieved by shaking and cold water? Is it pain at the hand while doing some activity? Or do you have any past medical condition that I should be aware of? Do you undergo dialysis? And can I see your hand? By seeing the hand, you will be automatically able to identify whether this is AV fistula or whether this is joint pain like psoriatic arthritis or whether this is rheumatoid arthritis. Raynaud's phenomenon. So this is all for hand pain. Please ask me if there is any question from this prompt, because this is very much important prompt and this is a triple step prompt. If there is no question, please give me a thumbs up reaction in the comment section so I will be able to make it understand that this is clear to all.
Hello, Dada.
Yeah, please tell me.
You told the rheumatology screening question will not be appropriate for the seronegative arthritis.
Yeah, it will not be appropriate.
So there are separate questions.
Yeah, I will provide it also.
Okay,
I will discuss it in that next prompt also.
Okay.
Okay. Any other question from any candidate? Okay.
I had a
Doctor?
question.
Yes,
Yes.
doctor.
The AV fistula disease. What I heard that if we tell thrombosis or stenosis, we are gonna differentiate by presence or absence of bruit or anything like that.
Yes, doctor. But thrombosis may not be there. If there is thrombosis, you will not be feel any bruit or any. You will not hear any. What is it called? I have forgotten the term.
Yes, in thrombosis there will be no bruit.
Yeah, it will be no bruit. But in the PACES exam, in this case also came in this dietary in the Delhi. That patient was having bruit. So that means it is functioning. But if you don't find the bruit, this is thrombosis or stenosis. You can keep it in the differential diagnosis, doctor.
Okay.
Okay, Dr. Anusha has made another question that I did not get your point, doctor. Can you make it clear? Dr. Anusha, if you have any question, can you please make it clear by unmuting yourself so that I can repeat the answer? Okay, please show the slide of joint pain. Okay, joint pain slide. Okay, this is joint pain slide. So, Dr. Raisa, you are right. Whenever we are not finding the bruit, it is the differential diagnosis will be thrombosis or stenosis. But in the exam, there were bruit. That's why I just did not keep it there.
So then how are we going to, do we continue giving dialysis through this AV fistula where we see there's a local infection or any of these differentials? Because that is the next question the examiner shall we keep giving dialysis through this?
Okay. Just give me answer. You are okay. Your question is very much valid. I am giving you the hint. You are working at the ST3 level, and your job is to form a multidisciplinary team. So what will be your task then? If the patient asks you that, where can I take the dialysis then?
I'll consult a kidney doctor. I'll refer you to the kidney clinic.
Wonderful, doctor. You have just to tell that I will talk to the kidney doctor and I'll get back to you after getting the answer.
And sir, so the examiner suppose ask this question then?
No, he will not ask. If they ask, you have to tell that I would like to talk to the kidney consultant, nephrologist.
Okay, sir. Right.
Look, doctor, our job is working there as a registrar, not as a consultant. And this decision will be taken by the consultant.
Okay, sir.
Okay, so I think I should add one more DT here, that is thrombosis or stenosis, because it can be there also. But the case, what was there was, yeah, any other question?
So they didn't agree probably, I think, on thrombosis and embolism, stenosis.
Sorry?
They didn't agree, like you said, these three, and then you're adding thrombosis.
Yeah. Whenever there is no bruit, whenever you are there are some.
Okay.
Yeah. Whenever there is no bruit, whenever you are doing the physical examination, you are not getting any bruit. That case, you can tell it due to thrombosis or stenosis. But up to now, the cases which has come in the Delhi center, the patient was having bruit.
Right, sir.
Okay, are you getting it, doctor?
Yes, sir, got it.
Okay. Now let's proceed to the next prompt, that is low back pain. So it will be like that. You will be given a prompt like this 30-year-old man has come with low back pain. Please talk to him, examine him, and meet his concern. So for any pain, the first question will be, can you please show me the site of the pain? Because one time in the Pondicherry, it came with the prompt with the diagnosis of pyelonephritis. So if it is due to some musculoskeletal pain, the first question will be, do you have any morning jamming? Remember, morning stiffness is a jargon, but morning jamming is not. Then after asking about the morning jamming, we have to ask about the duration, whether this is more than 30 minutes or less than 30 minutes. Then we have to analyze the low back pain using the mnemonic, Odipara, and Lee code. After that, we have to exclude the red flag sign for any low back pain. Please don't forget it. What are the red flag signs? The red flag signs are whenever we are having any cord compression or any cordicular syndrome, that are the red flag sign. So we have to remember the red flag sign of low back pain. They are any weakness of the lower limb, any change in sensations around the private part, any change in sensations of the lower limb, any loss of bowel and bladder work. Then, does the pain wake you up at night? Nighttime pain is a red flag sign. So, please remember these 5 questions. They are red flag questions for low back pain. For any low back pain, we have to rule out from the history this red flag sign. Please don't forget it. Then we have to ask that any other joint pain or not. Then let's come to the differential diagnosis. So if there is morning stiffness or morning jamming more than 30 minutes, it will be inflammatory back pain. If there is not, then this is mechanical back pain. For inflammatory back pain, the diagnoses are seronegative spondyloarthritis. They are either ankylosing spondylitis, psoriatic arthritis, reactive arthritis, or enteropathic arthritis. I'm going to tell you what will be the screening questions for each. The mechanical causes of low back pain are trauma or septic arthritis or osteoporosis or osteoarthritis, metastasis, multiple myeloma, prolapse of lumbar intervertebral disc or PLID or psoas hematoma. So let me tell you the screening question for inflammatory arthritis first. And after that, I'm going to ask you some real basis example. That's some real basis cases example. So let me start from the psoriatic arthritis, because for ankylosing spondylitis, basically there are no screening question. This is a diagnosis of exclusion for any seronegative spondyloarthritis. For psoriatic arthritis, we have to ask about the skin rash. For reactive arthritis, we have to ask any unusual discharge from your private part. And also, we have to take the sexual history, that any casual sexual partner. For enteropathic arthritis, we have to ask about the bowel ward. Specifically ask about the any loose motion, ruling out Crohn's disease. Any blood in motion, ruling out ulcerative colitis. Please ask this question specifically. Any loose motion, any blood in motion. Loose motion for Crohn's disease, blood in motion for ulcerative colitis. And for ankylosing spondylitis, there is no screening question. Low back pain itself is the presenting symptom of ankylosing spondylitis. There can be other joint pain also. So let me give you some example. Okay, Dr. Rania has asked a question that what is the Odipara and Lucor? Doctor, it was explained in the earlier session. Okay, let me repeat it just a little bit, recapture what is Odipara. Here O goes for onset, D goes for duration. This is provided in the PDF. I goes for initial episode, P goes for progression, A goes for aggravating, R goes for relieving factor, and A goes for associated features. These are Odipara. And Lacos goes for any pain. For any pain, first we have to ask about the history of trauma, then location, intensity, quality, and radiation. So this goes for liquid. This is a funny mnemonic, and this is provided as a PDF sheet to the active participant. So let me ask you some real paces cases example. At one time, a case came, a 60-year-old male. Okay, I would like to hear from each and every candidate who can give the answer. With low back pain. So, after entering the station, he is telling you that I'm having pain for the last 3 days. And in the past medical history, he is telling that I'm a diagnosed case of high blood sugar, and 5 days back, I got injured at my leg while gardening. So, can anyone tell me what is the diagnosis here?
Discitis, sir.
Wonderful, doctor. Discitis. This falls in the septic arthritis. Septic arthritis can be discitis, can be abscess, but discitis is the best answer. Okay, let me give you another example. Have you seen how past medical history is very much important?
Yes, sir.
Let me give you another example. Okay. 35-year-old female with low back pain. She's also having some loose motion in the past medical history, which was diagnosed as celiac disease. So, what will be the diagnosis here? What will be the, sorry?
Osteomalacia.
Osteomalacia.
Osteomalacia or osteoporosis? Yeah,
Osteomalacia, sir. Malaysia first, sir.
Yeah. It will be the diagnosis. These are real cases example. Then let me ask you another question. A case came. It was a 65-year-old male with low back pain. In the past medical history, it tells you that 5 years back, he was having prostate carcinoma. He was treated and declared cured. In the drug history, he used to take anti-androgen. Like flutamide or something like that. So what do you think? What is the diagnosis or differential diagnosis?
Is the osteoporosis due to the drug?
Yes.
Anti-androgen drug.
Another can be metastatic multiple myeloma.
Yes,
or any
doctor. Not multiple myeloma, doctor. Recurrence
any
of
bone.
yeah, yes, doctor. Recurrence of metastasis. That was the diagnosis there. One was osteoporosis due to anti-androgen. Another was metastasis. If the same patient, like she is 65-year-old female with low back pain, in the past medical history, she is telling you that she has resected breast cancer and she was diagnosed, she was declared cured. So the differential diagnosis will be also the same due to metastasis. That is why I can tell you that past medical history, JAK history, and family history is very much important. All these cases will be provided to you in PDF format to practice between yourself. And in the separate section, I will give you a recording where you will gain access what are the physical examination, investigation, and management you have to do for each case. Let me ask you another question. It is a real case. A 40-year-old male with low back pain. In the past medical history, the patient tells you that he is a case of mitral valve replacement. You tell you that I had valve surgery. In the JAK history, he is taking warfarin. So what will be the diagnosis, doctor? Can you pick up from the list of mechanical diagnosis?
Psoas hematoma.
Yes, doctor, Psoas hematoma. Yes, Psoas hematoma. It was the diagnosis there. So can anyone tell me, this patient was taking warfarin for a long period of time. So up to now, he has not developed any hematoma or something like that. So why suddenly he will develop hematoma? What can be the reason?
So must be on some antibiotics or some medication which
Yes.
must
Yeah,
have
dry interaction.
interaction.
Wonderful, doctor. Very good, doctor. You're being pro. You have got to the point, and this will be the diagnosis. We have to find out what triggered the warfarin toxinization. Like it can be due to binge drinking, or can be due to some medication, like antibiotic. We have to identify this. So just asking the past medical history and drug history is not important. We have to ask what caused this warfarin, that overall warfarinization. So these are some real examples. And by asking the past medical history and family history, drug history and family history, you'll get your diagnosis in most of the cases. And if there is any morning stiffness, it is inflammatory back pain. For PACES exam, the inflammatory back pains are the most important one. And there are lots of physical examination we have to do. And what are the physical examination we have to do? It is explained in detail in a separate recording. Like for any seronegative spondyloarthritis, we have to remember the mnemonic 5A. Starting from the eye. That is, at the eye, we have to look for anterior uveitis. These are explained in detail in the physical examination video. Then at the lung, we have to look for apical fibrosis. At the heart, we have to look for aortic regurgitation. At the tummy, we have to palpate for hepatosplenomegaly. That is evidence that can be found in case of amyloidosis. At the leg, we have to palpate for Achilles tendinitis. So this is the mnemonic 5A. This is for all seronegative spondyloarthritis. And there are also many other examinations. These are explained in detail in a separate recording. And this is not possible to complete all the things in only this prompt discussion. Then, another important thing is, for any case of low back pain, never forget to examine the gait. If you forget to examine the gait, the examiner will forget to give you mark in the physical examination. Because by checking the gait, you are ruling out the complication. If you remember the CCCA that confirm the diagnosis, find out the cause, then find out the complication and association. Here the complication is any low back pain, any knee pain, any ankle pain we have to check the gait. Any hand pain, we have to check the functional capacities of hand. This is a must. And what are the important physical examination that many candidates make mistake, that they forget to examine the lower limb. At least examine the plantar. If you forget to examine the other thing, at least examine the plantar. This is a must to the examination for any low back pain. And there are other examinations also, especially for seronegative spondyloarthritis, like the neck movement, hip movement, and Schober test. And all of these are explained in detail in the physical examination video. So this is all for low back pain. Please ask me if there is any question from this prompt. Dr. Mayan has asked, what is the importance of less than or more than 30 minutes in case of morning stiffness? Yes, doctor. In case of inflammatory arthritis, the morning stiffness will be more than 30 minutes. Sometimes there can be less than 30 minutes in case of some mechanical pain, like osteoarthritis. There's a special type of osteoarthritis. They are called inflammatory osteoarthritis. These are very real diagnoses. But in the PACES exam, whenever we are given any inflammatory back pain, their morning stiffness will be more than 30 minutes, not less than 30 minutes. And we have to identify it. Whenever there is morning jamming, the next question will be, for how long? Is it more than 30 minutes or less than 30 minutes? Because there are some inflammatory osteoarthritis like pain where there is less than 30 minutes morning jamming, but these are rare. Is it clear, Dr. Mayan? Okay, any other question from any candidate? Okay. If there is no question, then let's proceed to the next prompt. That is knee pain. So for knee pain, again, we have to ask about the morning jamming. If there is morning jamming, we have to ask whether this is more than 30 minutes or less than 30 minutes. Then using the OD paramnemonic to analyze the symptom, then liquor, then any other joint pain. So if the knee pain, if there is any morning stiffness, the differential diagnosis is seronegative spondyloarthritis and rheumatoid arthritis.
Can you show the previous slide, please?
Okay, doctor. First, we have to ask about the morning jamming. Then we have to analyze the symptom using the mnemonic OD para. Onset, duration, initial episode, progression, aggravating factor, sorry.
Yes, sir, hold on.
Okay.
Yeah.
Progression, aggravating factor, relieving factor, and associated symptoms. Then analyzing the pain using the mnemonic LICOD, location, intensity, quality, and radiation. Then for any pain, we have to ask if there is any other joint pain. Is it okay, doctor?
Yes, sir, yes.
Okay. Next, approach to the knee pain. So the differential diagnosis of knee pain will be based on the morning stiffness. If there is morning stiffness, the differential diagnosis will be either seronegative spondyloarthritis. There are 4 seronegative spondyloarthritis and rheumatoid arthritis. And if there is no morning stiffness, the differential diagnosis will be GHOST. The mnemonic is GHOST. Here G goes for gout and pseudo-gout. H goes for heme arthrosis. O goes for osteoarthritis. S goes for septic arthritis. And T goes for trauma. This goes for ghost mnemonic. So let's discuss the screening question first from the seronegative first for the inflammatory knee pain. For ankylosing spondylitis, we have to ask about the low back pain, because in ankylosing spondylitis, apart from low back pain, there will be knee pain. It will not be given like in the exam that only knee pain patient, presenting with ankylosing spondylitis. The patient will have low back pain along with knee pain. For psoriatic arthritis, we have to ask about skin rash. For enteropathic arthritis, we have to ask about the bowel habit, any loose motion, any blood in the motion. Then for reactive arthritis, we have to ask about any discharge from the private part, like any urethra discharge. And we have to specifically take sexual history. That do you have any partner? I'm sorry to ask this personal question. Any other partner apart from the casual regular partner? So these are the screening questions for inflammatory knee pain. Then, if the knee pain is mechanical, the mnemonic is gout. If the cause is gout, how to identify this gout? I have told you that I will discuss detail about gout. So, to identify the causes of gout, there is a mnemonic. The mnemonic is DHL plus psoriasis. Here D goes for 3D. Their diet, drug, defect in kidney function. Diet means if the patient takes seafood and meat product more. So we have to just ask about the diet of the patient. After asking the patient that what about your diet, the patient will typically give you the answer that I take excessive seafood or something like that. Then another D goes for drug. Here, the drug causing gout is thiazide diuretics. In the PACES exam, only thiazide diuretics is important. Then another D is for defect in kidney function. CKD patient can develop gout, you all know that. So here goes for D3. Now the next is H. H goes for 5H. That is history of high blood pressure, history of high blood sugar, history of high blood cholesterol, history of alcohol, and history of smoking. So these are basically components of metabolic syndrome. And this has come in the PACES exam, that patient is having knee pain and he is having component of metabolic syndrome. So automatically the differential diagnosis will become gout. Then L goes for lymphoproliferative disorder and myeloproliferative disorder. So for any cancer or any lymphoproliferative or myeloproliferative disorder, this is basically cancer. So for any cancer, just remember a mnemonic to screen any question. That is the rule of triple L. What does this mean? 1L goes for loss of weight, then loss of appetite, then lumps and bumps in the body. I'm again telling, for any cancer, to screen the cancer, the question will be triple L. They are loss of weight, loss of appetite, lumps and bumps in the body. That is triple L. So by asking this DHL and for psoriasis, we just have to ask, is there any skin rash? So by asking about the DHL and psoriasis, we can rule out the gout. Is it clear to everyone how to rule out the gout? Please ask me if there is any question. Okay. Then another DT is pseudogout. For PACES exam, the pseudogout important are the hemochromatosis. Apart from hemochromatosis, up to now, I have not seen any other DT coming with a prompt of knee pain. This hemochromatosis, most of the cases, it is due to repeated blood transfusion, like with the past medical history of hereditary spherocytosis or thalassemia, and the patient is having repeated episode of blood transfusion. Now the prompt is joint pain, that is knee pain. So this knee pain is there for the secondary hemochromatosis. Up to now, apart from hemochromatosis, I have never found any other cause of pseudogout coming in the PACES exam with the prompt of knee pain. So I will suggest you to just keep in the mind, see hemochromatosis. The H goes for hemarthrosis. O goes for osteoarthritis. For hemarthrosis, typically the patient will have any past medical history of bleeding disorder, like the hemophilia. For osteoarthritis, the patient will typically be postmenopausal female. Male can also be there, but it will be older patient. For septic arthritis, we have to ask about do you have any high temperature? That is raised of body temperature. Then T goes for trauma. We have to take history of any injury. So in this way, we have to rule out ghost. First, for the gout, we have to take history of the DHL. For pseudo gout, we have to ask about the past medical history. In the past medical history, the patient will typically give the answer. For hemarthrosis, also the diagnosis will be found from the past medical history. For osteoarthritis, the diagnosis will be found from the age. For septic arthritis, we have to ask about the high temperature. Only raise up body temperature will be okay. Then for T, we have to ask about any history of injury there or not. So again, we have to examine the gait. We have to tell the patient, can you please walk for me?
So D3HL plus psoriasis you have written. What does that mean, sir? Gout causes D3HL plus psoriasis?
Psoriasis patient can also have gout.
Okay.
So it is mean DHL. I think you know what does DHL mean. It is actually company.
Yes.
Yeah. This goes for DHL plus psoriasis.
Yes, sir.
So each of the differential diagnoses is important mentioned here. All of them have come in the PACES exam. Like the gout has come, pseudogout has come, osteoarthritis has come. Okay, Dr. Isa's medication, do you need to exclude the other causes of pseudogout as well? Actually, Dr. not needed. You can just remember the mnemonic ghost. For any case of mechanical knee pain, you can tell the differential diagnosis of the gout. But again, you have to mention what goes against the differential diagnosis. Suppose, let me give an example. Like you'll diagnose pseudogout, the patient is having secondary hemochromatosis. After entering the station, automatically you will found some stigma of CLD because repeated blood transfusion has caused deposition in the knee, but before knee, it will affect the liver. My point is not that. During telling the differential diagnosis, you have to tell that my first differential diagnosis is pseudogout, but I have other differential diagnoses, like it can be osteoarthritis. But against that, from the physical examination, I did not get any crepitation. You have to feel for crepitation, and this is explained in detail in the physical examination video. This can be septic arthritis, but against that, the temperature was not high. This can be trauma, but against that, there is no history of injury. This can be due to gout, but against that, I have not got any history in the form of dietary history or medication history or any affection of kidney function, which can point towards gout. So you can mention any differential diagnosis, even from the mnemonic, but also mention what goes against each differential diagnosis.
Right.
So, Dr. Isa, is it clear to you?
Yes.
Okay. And also, never forget to examine the gait. The cases that have come to now, I will provide you in the PDF section in the form of PDF. Like there are many cases from the knee pain, and you have to take preparation how to approach to a case of knee pain. After that, you have to cover the physical examination, investigation, and management. If possible, try to make some note of yourself so that after completion of the session, after completion of the course, you can it will help you in the revision. Then you have to start practicing with each other, and you have to judge each other using this mark sheet. Like Dr. Brevis will practice with Dr. Isa, and Dr. Brevis will give some case, exactly the 30 cases that I will give you as a homework. And Dr. Brevis has to assess how Dr. Rice is performing. And after seeing the performance, Dr. Brevis has to give mark using the skill, like how the physical examination, how it would like to be scored, and in the identifying physical sign and clinical communication. And you have to practice it, doctor, because you have to think like the examiner also. After that, you will be able to get the full mark. And it will automatically become easy after repeated practice and after 2 or 3 episodes of session. So, do anyone have any kind of question from this knee pain prompt?
No, sir.
Okay. Now let's proceed to the next prompt. The next prompt is shoulder pain. It is not that much important. It is actually, if you remember, it's one step prompt. Yeah, it is actually, double step prompt. So shoulder pain. So the prompt can be from outside that this patient has come to you. You will be given the name that this gentleman, Mr. Jackson, has come to you with a shoulder pain. Talk to him, examine him, and meet his concern. So right after entering the station, our first job will be to identify whether this is unilateral shoulder pain or bilateral shoulder pain. You just have to ask the patient, where do you feel the pain exactly? He will show you. If the pain is bilateral, he will show you both of his shoulder. So then we have to analyze the symptom using the mnemonic ODPARA. Here O goes for onset, duration, initial episode, progression, aggravating factor, relieving factor, and associated symptoms. Then LACOR. There LACOR goes for location, intensity, quality, and duration. And also for any joint pain, this is a shoulder pain. Shoulder joint is a joint. You have to ask about any other joint pain or not. So if it is unilateral shoulder pain, in the PACES exam, it is adhesive capsulitis. We have to take out the past medical history. In the past medical history, the patient will typically give a history of diabetes. It will be mechanical type of pain. The differential diagnosis can be osteoarthritis or supraspinous tendinitis. Apart from this, nothing has to be remembered for unilateral shoulder pain for the PACES exam. Then, if the pain is bilateral shoulder pain, for the PACES exam, the diagnosis will be either polymyalgia rheumatica or polymyositis. In polymyalgia rheumatica, the patient will have bilateral shoulder pain with stiffness, but not weakness. In polymyositis, the patient will have bilateral shoulder pain or diffuse body pain, but no stiffness, but there will be weakness. Remember this thing. Let me write it. There will be no weakness, in polymyositis, there will be positive weakness. Keep it in mind, doctor. And also we have to check for the function and capacities of both shoulder. How to check it? Just check for the proximal weakness. It will be covered in the physical examination video that we have to check for the proximal weakness of the hand. In this way, we will already check the function and capacity of shoulder, whether the patient is able to raise his or her shoulder above his head. We have to do this examination in the physical examination. So this is all for shoulder pain. And this any other joint pain, let me give you an example. What is the importance of this question? Suppose the prompt is knee pain. And whenever you are asking that any other joint pain apart from this knee pain, the patient tells you that yes, I'm having pain at big toe that comes and goes. So automatically, what will be the diagnosis? Can anyone reply?
Gout.
Gout.
Yes, doctor. Gout. This case has come in the PACES exam. I have just told you to keep some example. What is the importance of asking any other joint pain? So do anyone have any kind of question from the prompt of shoulder pain?
What did you tell about polymyositis and polymyalgia rheumatica?
Okay. In polymyalgia rheumatica, there will be no weakness, but there will be stiffness. But in polymyositis, there will be weakness, but no stiffness.
Okay.
Okay, doctor. Okay. So if it is clear, let me proceed to the next prompt, that is hip pain. This is also a double step prompt. And for any hip pain, first you have to localize the site of the pain, then analyzing the symptom using the mnemonic ODPARA, then LACOR. Then for the PACES exam, these are the two important differential diagnoses that has come up to now. And to know it, actually this hip pain prompt comes most often in the Middle East, like the Oman, Jordan, but it is not that much common in India and Bangladesh for the PACES examination. This prompt usually comes in the Middle East, but can be given. So keep it in mind. So what will be the differential diagnosis for hip pain? The most important differential diagnosis will be avascular necrosis. This can be due to steroid or alcohol or sickle cell disease. So what will be the trick? Directly go to the past medical history. If the patient tells you that, yes, I'm a case of renal transplant and I used to take steroid, so it will be avascular necrosis. If in the Sajid format, the patient tells you that I'm taking excessive alcohol, then this is due to alcohol-induced avascular necrosis. If the patient in the past medical history tells you that I'm a diagnosed case of sickle cell disease, then this is due to sickle cell crisis. Of course, whenever there is sickle cell crisis, there will be any recent history of loose motion, which precipitated the sickle cell crisis. Please keep it in mind. Another DT will be salmonella due to osteomyelitis. So it came as a DT in the Middle East. The scenario was the patient was a diagnosed case of sickle cell disease, and recently she had some loose motion. After that, she is having this hip pain. So in the differential diagnosis, automatically sickle cell crisis will come. Apart from sickle cell crisis, another DT will be osteomyelitis due to salmonella, because salmonella can cause loose motion, and this salmonella can cause osteomyelitis. That is why salmonella is kept as the differential diagnosis. And what are the examination we have to do for hip pain? These are explained in detail in the physical examination video. And also, for any hip pain, offer to check the gait. If the patient cannot walk, the examiner will tell you that no need, but you have to offer to check the gait. So does anyone have any kind of question from the prompt hip pain?
So sensory examination we have to do for the leg and the hip pain?
All the examination of the lower limb.
Okay.
You have to
neurological, the sensory and motor both.
Actually, it is very much important for low back pain, but for the hip pain, there is specific examination.
Okay, sir.
If time allows, you can do the sensory examination, but that is not needed actually.
Okay, sir.
Any other question from any candidate? Okay, now let's proceed to the next prompt. That is ankle pain. Ankle pain is almost similar to the knee pain. That is, after analyzing the symptom using the mnemonic Odipara and Leucor, then we have to ask about any other joint pain. That if there is morning stiffness, the differential diagnosis is seronegative spondyloarthritis or rheumatoid arthritis. If there is no morning stiffness, the mnemonic is GHOST. Yeah, G goes for gout and pseudogout, H goes for hemarthrosis, O goes for osteoarthritis, S goes for septic arthritis, and T goes for trauma. And offer to check the gait, but the patient will not be able to walk if he is having or he or she is having real ankle pain. But we have to offer that I want to check the gait. But if the patient is not able to walk, the examiner will tell you that no need. So this is all for ankle pain. Any question from any candidate?
So making the person to walk is basically checking for the myopathy?
No. Okay, let me get back to the mark sheet again. So if you remember from the mark sheet, in the physical examination, we have to follow the triple CA. And one of the C is complication. We have to check the complication of the given symptom. So
Okay.
due to the ankle pain, the patient will not be able to walk. So we have to tell the patient, can you walk for me? If the patient tells you that, no, I cannot walk. So it is a positive finding that I have identified that patient cannot walk. Also, it is important for knee pain and low back pain because all this pain can affect the walking. Are you getting? And for
Yes.
exactly the same way, if there is any hand pain, for hand pain, the patient will not be able to the daily activity using his or her hand. So we have to check for the functional capacities of the hand. And can you remember how to check the functional capacity of hand? Can you recap it for me?
Yes, so we'll ask the patient to close the fist and open it. And,
Yes, doctor.
And buttoning and unbuttoning, or he can pick up the pen. We can give him a
Yes.
pen to see that.
Yes, anyone will do. That is easy. Paces exam actually, doctor, very much easy. Just you have to do the repeated episode of practice. It is 30% knowledge and 70% practice. You will get it automatically by the course. Okay. Then the rest are one-star prompt, and these are very much less important. A neck pain has come only one time in the PACES exam, and the diagnosis was ankylosing spondylitis. So apart from neck pain, the patient will typically give you history of low back pain. So we have to analyze the pain using the mnemonic Odipara, then Liquor, then any other joint pain. The patient will typically reply you that I am having low back pain also. Then we have to approach in the same way. Like for the neck pain, if the patient is having morning stiffness, it will be spondyloarthritis, it is seronegative spondyloarthritis and rheumatoid arthritis. If there is no morning stiffness, it will be cervical spondylosis or cervical radiculopathy or cervical myeloradiculopathy. But it has not come up to now, anytime. Only this ankylosing spondylitis has come only one time in the PACES exam. And that's why it is termed a one-star prompt. So I hope this is clear. Now let's proceed to the next prompt. This is diffuse body pain. This is also a one-star prompt. That is, it is not that much important for the PACES exam, but it has come only 1 or 2 times. So after analyzing the symptom using the mnemonic Odipara and Liquor, we can directly go to the differential diagnosis. For PACES exam, the important differential diagnosis for diffuse body pains are dermatomyositis and polymyositis, rhabdomyolysis, viral myalgia, osteomalacia, and polymyalgia rheumatica. So what will be the screening question for dermatomyositis and polymyositis? You have to ask, do you feel difficulty in combing your hair? And for dermatomyositis, any skin rash. For rhabdomyolysis, typically the patient will give you some history in the past medical history that he had some recent episode of running in the marathon, or he is taking some cocaine that is causing some rhabdomyolysis. So it has to be identified from the past medical history. Then for viral myalgia, we have to ask about, is there any sore throat? For osteomalacia, we have to ask about the sun exposure. And for polymyalgia rheumatica, we have to ask about the stiffness. And can anyone tell me what is the important associated disease for any case of polymyalgia rheumatica? We have to rule out.
Giant cell, sir.
Sorry, doctor.
Giant cell arthritis.
Yes, doctor. Giant cell arthritis. And in the PACES exam, typically it will be there. And the examiner will see whether you are ruling out the association of giant cell arthritis for this case. Okay, let me ask you a question. Suppose the case is, this case is coming the PACES exam. Suppose the case is rhabdomyolysis. The patient is telling you that recently I had a marathon. Okay. So the patient is telling you that recently I took part in a marathon. I had run for a long period of time, and I had diffuse body pain. So for this body pain, I started taking some painkiller. So what do you think? What is the diagnosis is rhabdomyolysis for sure. But what is the important safety netting we have to tell to this patient? Can anyone tell me? Look, I'm again telling. Patient is having diffuse body pain due to taking part in long marathon, and his urine output is being reduced for this diffuse body pain, and he's taking painkiller for that diffuse body pain. So what is the important safety netting? Yes, Dr. Bhinak has got a safety netting. Can anyone tell it? Unless you tell it,
What
the
kind
examiner
of
will give
painkiller
diffuse
taking?
body pain. No, doctor. What kind of painkiller takes, it does not matter. We have to tell the patient that stop taking the painkiller. That's all. Are you getting it, Dr. Isa?
Yes.
So whenever there is affection of kidney, like this patient recently took part in marathon and his urine output was reduced and he was having diffuse body pain. To meet this body pain, he is taking painkiller. So we have to tell the patient that to stop taking painkiller. This is the important safety netting. We have to keep it in mind. Unless we tell it to the patient to stop the painkiller, we lose the mark in the clinical communication skill. That is important safety netting. That is why it is very much important to practice between yourself to judge each other using the mark sheet. And believe me, if you continue doing this, after this 1.5 months, you will become the mentor. It will no need of any other if you continue doing this. This is very much easy. So this is all for today. And the prompt came with the prompt of multiple body joint pain. Diagnosis was SLE. This case came in the Dhaka center. That. The patient was also having some kidney involvement. So I already have told you that what are the screening questions for any rheumatological system. The flowchart is there and it will be provided to you. So for any rheumatological disease, we have to ask about the water work because any rheumatological disease can affect the kidney. So this is all for today. Please ask me if there is any question from today's prompt.
So in dependence contracture, if the patient comes with the hand pain, the same sequence of examination has to be followed.
I have never seen Dr. Dupuytren's contracture coming with a prompt of hand pain. Up to now, in the last 4 years, I have never seen in any carousel, any Dupuytren's contracture coming with a prompt of hand pain.
Okay.
Have you got it anywhere?
So I saw it somewhere actually.
But up to now, I have never heard this case coming.
So must be
Dupuytren's
old one then. Yeah, maybe some old
can
case
be.
from some book. I don't
But in the
remember, so
last.
I must have written it somewhere. I'll definitely share if I get it.
Okay, doctor. That's okay. Dr. Raisa, should we put fibromyalgia as DD? Yes, doctor. Fibromyalgia will be, sorry, it was my wrong. Fibromyalgia will be there automatically. I have not put it. Sorry, doctor. Thank you for making me correct. It will be there. I have forgotten to put it on. In the differential diagnosis of diffuse body pain, fibromyalgia will be there automatically. We have to take the history of mood. That what about your mood? So this will be the differential diagnosis. Dermatomyositis, polymyositis, rhabdomyolysis, viral myalgia, osteomalacia, polymyalgia rheumatica, and fibromyalgia. And this case is also there. You will get this case. The fibromyalgia has come. The prompt was actually fatigue. The approach to fatigue will be discussed later on. And the differential diagnosis was fibromyalgia and chronic fatigue syndrome. How to rule it out, it will be discussed as the situation arises. So thank you, Dr. Raisa, for making me correct. I just forgot to mention this differential diagnosis, and this should be there. So any other question from any other prompt, doctor?
Yes, I had a question. That is,
Sure, doctor.
if low back pain comes, what DD we should keep for acute low back pain?
Yeah, acute low back pain most likely will be septic or trauma, or can be due to osteoarthritis. Metastasis can be also acute low back pain, doctor. And PLID can also be acute. Any type of mechanical pain can be acute pain, doctor, except for osteoporosis. Are we getting it, Dr. Isa?
Yes. Can I put any infection like
Yeah,
TB or?
yeah. This comes under the prompt of septic. Actually, from the septic, TB can be there, discitis can be there, and brucellosis can be there. But brucellosis is important for the Middle East, not for the India and Bangladesh. For India and Bangladesh, TB and discitis is important. But to rule out TB, we have to look for the respiratory symptom. And for discitis, we have to look for the past medical history of getting injury. Like the patient can have some recent injury to in the form of scratching or recent cannulation. Are you getting it, Dr. Isa?
Yes. Thank you.
For acute low back pain, apart from osteoporosis and multiple myeloma, I think you can put all the differential diagnosis of mechanical low back pain. Any other question, doctor? So, Dr. Isa, let me ask you another question. For low back pain, what is the important examination you have to do to rule out the complication?
Neurological lower limb examination and
Wonderful. And
mm,
how to rule out the complication? Yes, doctor, never forget it. Examine the gait.
okay.
So, any other question from any other candidate? So, let me ask one by one. Dr. Partho, are you there?
Yes, brother. I'm here.
Do you have any question from any prompt?
No, right now, no. It was excellent session, brother.
Okay. So you have to start doing the homework from tomorrow, doctor. Okay. Dr. Nozrul, do you have any question?
So, Dada, excellent session.
Okay.
So you are assuring us not to put any other different DDs, uncommon DDs besides this?
No, doctor. No, doctor. I will assure
Okay.
without it. Up
Thank
to
you.
now.
Thank you. Yes.
So if you
Hello,
take the
doctor.
preparation, yes, doctor, please ask.
Can you please provide the slides?
Actually, doctor, slides are not provided, but the PDF of the original, this one, it is provided to the active participants.
Okay.
And this is provided in the form of recording. So you can make note in the form of recording anytime.
Brother.
Yes, doctor.
So I'm quite unable to take all the screening question no in my notes. So
You can get it in the recording, doctor.
Okay.
No problem. Okay. And in the meantime, during this 1 month and 1 week period, in the meantime, anytime you are facing any kind of confusion or problem, please contact with me at my WhatsApp number. I will get back to you as soon as possible. But you have to do regular practice. And at every night, I will individually take news from every active candidate, whether they have practiced that day or not. Please, you have to keep the accountability to me, directly to me, whether you are practicing or not. After this 1 week, 1 month and 1 week period, I will never disturb you. But during this time, you have to practice, doctor, every day. After you have to, first you have to take you have to complete taking the preparation for each prompt. Then from the, okay, let me give you some example that, the example of the cases there. So these are the examples. From the musculoskeletal system, these are the cases. There are about 31 cases. So you will be given this PDF in the form of picture and all the other necessary details. So this 31 PDF access will be given to individual one. Then with a separate access, you will get the examination video for each of the cases separately. Like here, you will be described how the physical examination has to be done. First, already you have done the patient. So after going through the recording, you have to make your note for each of the 31 cases. Then you have to start practicing between each other. And I know this takes a lot of time and a lot of effort, but you have nothing to do. All of the active candidates have exam. So you have to complete the course and you have to complete all the cases as soon as possible. And at the next session, after discussing the prompts from the neurosystem, I will start practicing one-to-one. And I will give you exactly the same cases from these 31 cases. And you have to practice with me. And at the same time, I will, let it be for tomorrow's session. You will understand, because instead of judging with myself, I will make you one another judge one another. And I will help you how to judge each other using the mark sheet. But it will be discussed in the next session.
Dada,
Yes, doctor?
is the notes downloadable, or we need to take notes?
Yeah, you can download the PDF sheet and you can make notes, doctor. It is, it is okay, doctor. So, any other question? Dr. Anwar, do you have any question?
No, sir, I don't have. Thanks a lot, sir.
Okay, doctor. Dr. Kia, do you have any question? May I
No,
ask, Dr.
thank
Kia?
you. Thank you. No.
Okay. So, if there is no question, I can. Okay, Dr. Asa, the details showed in the slide would be in the PDF. Okay, doctor, actually, we have to write it down, doctor. The recordings will be provided within tomorrow morning at the Telegram channel, and this recording will be there for all the time. Even after completion of the session, up to your exam, or even after your exam, this recording will be there. You can take the notes anytime possible from the recording. So if there is no confusion, I would like to end the session here. And by tomorrow's morning, you will get the recording in the Telegram channel. And also, I will give you the access to the PDF and physical examination. Please provide me with your active Gmail or email to my inbox. I will suggest it to each and every active candidate so that I can provide you the access to the link. So up to now, good night, everyone.
Right, sir.
Thank you.
Good night.
Thank you.
Thank you, sir.